So, let me invite the first speaker to the floor. Professor Patrick CASTEL performs research, but also teaches on the topics that are at the crossroads of medicine, sociology, and public policies. He has done much work on the organization of cancer patient treatment, but also on the production of guidelines. So we asked him to throw his light on the mechanisms behind that gap between science, as we see it, and practice from the perspective of his research field. Research on the scene in which we as researchers operate, a scholarly look, so to say, on the game in which we play.
I thank all the organizers, all the people from the KCE, and especially Raf Mertens for inviting me. And this is a great honor, and I will try in this difficult exercise to make a broad overview of some relevant work by sociologists and political scientists about evidence-based medicine in general and guidelines in particular. The explicit goal of evidence-based medicine is to make decision-making more rational. Evidence-based medicine principles recommend that health decisions be grounded on methodic and well-reasoned analysis of the literature. This decision may be clinical decision or regulative ones, such as drug authorization or health technology assessment. Reciprocally, evidence-based medicine recommends distrusting judgments which are based on individual experience or intuition. More generally, evidence-based medicine recommends to adopt an agnostic position towards what has not been proved yet. Evidence-based medicine movement was pronounced as a paradigm shift in medicine. This approach has been successful far beyond medicine, and indeed, as a commentator wrote, we now have evidence-based everything, including education, policy, and nursing, and so on and so forth. I recall just the three major tools that are designed to help actors to take rational decisions according to evidence-based medicine. The first one is the randomized clinical trials. The second one is meta-analysis. And the third one is clinical practice guideline. The Institute of Medicine, the American Institute of Medicine, define guidelines as statements that include recommendations intended to optimize patient care that are informed by the systematic review of evidence and an assessment of the benefits and harms of alternative care options. So these clinical guidelines should be based on scientific evidence and notably on meta-analysis and the results of the clinical trials. Debates about guidelines largely overlap with wider literature on EBM. Indeed, we find out similar critiques about their basis as well as their unintended consequences. In this presentation, I will try to show that this project and its implementation are not only about rationality and reciprocally about irrationality, but also imply and entail irreducible political issues. Politics and power are also at the core of evidence-based medicine, and this has no dirty words in my mouth, quite the opposite. I will advocate that evidence-based medicine proponents, in their own interest, should acknowledge these dimensions. Making clear these dimensions may help to understand why evidence-based medicine in general and specific guidelines in particular are still debated in some places, why evidence-based medicine does not prevent local specificities and practices as well as guidelines variation around the world. And I have the intuition that paradoxically, Making clear this dimension may help to increase its acceptance. And finally, to paraphrase the title of a recent article by 2 American scholars, I will try to show that we live in a world of standards, but not in a standard world. So the first part of my speech will be about quantification in medicine in an historical overview. It will be very short, be sure, but still it's very important to see that these issues are not new, even if the term evidence-based have been coined only 15 years by the McMaster University Evidence-Based Working Group, as you may know, in Canada. But historians consider that it is a result of a far longer process. One may find early attempts to quantify medicine as early as the 18th century. And debates and controversy, of course, of a different nature at those times were not cooler than today. For instance, historians described harsh debates between the famous Claude Bernard and Lizalis against the uses of statistics, and who pretend instead that there was only one way to make more scientific medicine. It was to subordinate medicine to biology and to experimental methods. In other words, it was already a quarrel about how to quantify medicine and about the right founding principle of science and rationality. But the real impulse towards quantification took place at the beginning of the 20th century and developed after the Second World War. In a much quoted book, Harry Marks, an American historian, described all the difficulties with which controlled clinical trials came to be considered as the gold standard. For him, the emergence of clinical trials and evidence-based medicine is part of a distinctive and utopian project, a reform project aimed at establishing a profession, which means medicine, united by a faith in science. Harry Mark's stories begins in the early part of the 20th century, where leading medical academics sought ways to use science to protect the public from the excesses of capitalism and marketing, and especially drug companies. Harry Marks shows a shift away from a reliance on the personal credibility of the investigator of clinical trials and toward the faith in the power of formal statistical methods. These leading medical academics believe that these methods will help to separate the pharmaceutical wheat from the chaff and to protect consumers from unhelpful or dangerous therapies. These methods were thus intended to counterbalance the economic power of the rising pharmaceutical industry. This is quite an irony of history, that drug companies have become the leading force which sponsor clinical trials. This is quite an irony of history that these methods have become one of their main resources to enforce their power in the healthcare system. However, such conception of the role of statistics in modern life have become familiar and well diffused outside the medical field. Mark Berg, another famous scholar, a Dutch scholar, has shown that conceptualization of what scientific medical practice is and what medical practices problems are have actually changed in times and contexts. And the more recent conceptualizations have come to situate the discrepancies between scientific results and doctors' actual practices in the physician's limited cognitive abilities. And decision support techniques have changed accordingly. To improve physicians' practices, which means to overcome their cognitive biases and limited capacity to treat all the scientific literature, guidelines have been developed. To sum up this first part, after the Second World War, the traditional reliance on individual character gave way to a new ideal, And this ideal was a methodology grounded on an international model of science, the controlled clinical trial. Thus, some physicians have been crucial to promote protocols. Nevertheless, the rise of protocols cannot be disentangled from attempts for government, insurance company, hospital administrator, patient organization to get a grasp on the workings of healthcare. Regulation bodies and hospital managers, for instance, have increasingly oriented their efforts towards quality. They have expected that clinical trials and guidelines would be an efficient way to reduce health expenditures and to improve the quality of care. And in most Western countries, governments have come to create agencies such as KCE to assess the quality of new technology and new treatment and to produce guidelines. The second part will be devoted to an overview of the critiques of evidence-based medicine and guidelines. Evidence-based medicine has been the target by medical professionals, by philosophers, by social scientists. These critiques are mainly theoretical and many empirical studies should be conducted. But still, this does not mean that these people who formulate these critiques are not sincere, that they are irrational, and that these critiques are totally irrelevant. They should be, in my mind, taken into account, and I will come back later. For a first set of critiques, guidelines are considered as tools for managers, public policymakers, patients, and elite of the medical profession to reduce authority and autonomy of individual clinicians. They are expected to open the black box of clinical judgment and specify good practice. Thus, a guideline can be used as an evaluative yardstick to hold professionals accountable for others and gold standard treatments. For some analysts and professionals, guidelines would represent a shift of power from physicians toward health services managers on the one hand, and health services researchers on the other hand, such as epidemiologists, statisticians, health economists. All in all, some consider that guidelines might be one of the tools of the so-called audit societies that have been described by Michael Power, this audit society of the late 20th century. And this kind of critiques echoed well with some critiques by physicians about the so-called perils of cookbook medicine that you may know well. For some other critics, evidence-based medicine is also perceived as part of a rationalization process that is done in the name of cost-cutting and efficiency. Again, these critiques are mainly theoretical, but still there are some rare case studies who confirm that such concerns may be real in some contexts. In the UK, during the Tony Blair years, there have been strong concerns, strong controversy about the statutory obligation to fund interventions approved by NICE. This obligation was forcing some health authorities to divert funds from treatments which had not been scrutinized by NICE to those which have. And it was said that the resulting is a limited access to underpriced treatments and the perpetuation of some inequality. Some complain that decision-making by guidelines offered a means to depoliticize the rationing debate. They complain that it represented a technocratic fix to the legitimacy problem of rationing the healthcare system. Again, an American scholar, Gordon, studied the legislation regarding daily hemodialysis as a new renal therapy modality, and she documented how policymakers were all the more convinced about the necessity to conduct clinical trials before taking decisions, that it was a means to postpone the related new expenditures of poor Medicare and Medicaid. A third criticism is brought by what is called medical humanism. According to this view, evidence-based medicine would subvert the integrity and the complexity of clinical reasoning and of doctor-patient relationship and communication. Guidelines would be unable to take into account the complexity of the treatment process. In this perspective, evidence-based medicine will strip patients of their stories and the meaning of their experience, reducing them to passive recipients of doctor-centered communication. Again, and it's sad, we do not find many case studies, at least in sociology, but there are still empirical studies that seems to prove that they are not all wrong. There are, for instance, some interesting case studies about the flaws of evidence-based medicine when it does not take into account patients' value and preferences. Lehoux and Bloom, a Dutch scholar, study the health technology assessment of the cochlear implants for children. They made clear that sticking to economic and evidence-based medicine knowledge, the decisions did not take into account all other factors which were very important for the deaf children and their families. And these important factors for deaf children were, among others, language learning, psychological effect, social integration, that this technological would impact or not. And the way this health technology assessment was conducted was all the more damageable for deaf people and their family, that they tried to be recognized not as disabled people, but as a linguistic and cultural minority. And thanks to this process, they were reduced to sick people. And we can understand why there was this mismatch between some patient organization and the decision of technology assessments. As I said, the above discussed critiques rarely rely on empirical research on evidence-based medicine tools and practice. Things are quite complex, and we will go back to it later. However, to formulate such critiques towards these critiques should lead to reduce them to a question of irrationality versus rationality. I think it is counterproductive to treat them as merely irrational fears. On the contrary, one has to understand that what is at stake is a political debate about how medicine ought to be practiced and regulated. And this is important for agencies such as KCE to understand the nature of these critiques in order to deal with them and possibly give them some answers. Furthermore, some of these critiques have been more documented. This has been the case for the involvement of patients, for instance, for which much has still to be done. Bringing the patient back in evidence-based guidelines is clearly on the agenda of many guideline developers, researchers, and patient representatives. Guideline developers aim to adapt and use EBM guidelines to empower patients by improving informed decision-making and providing patients with an evaluative yardstick for their own care. However, researchers made clear that there are still much to be done in this area, and we'll come back later in further speeches, I'm sure. Including informing and empowering patients present its own challenges and of reductionism and violence. Sure, after much critique, EBM redefined evidence-based practice to emphasize the importance of clinical expertise and patient values in addition to research evidence. However, this still excludes those justifications from the evidence hierarchy, and they are designated as appropriate to the realm of practice, but not for science and decision. They are, so to say, second-class citizens in the realm of evidence-based medicine. Then I came to my third part. This is about the power struggles that take place around evidence-based medicine. It means that the knowledge that is produced by evidence-based medicine is shaped by the power relationship between actors in the healthcare systems, and conversely, that it may transform, that it may destabilize this relationship. true, there are cases where physicians resist the use of recommendation because they feel that they are imposed by outsiders and that they may be used by non-physicians to control their practices. However, surveys tend to underlie an overall lack of effect of clinical practice guidelines. And guideline developers are preoccupied with improving practices conformity to guidelines. And here is a famous article, which is as long as 1999, which complained about the lack of conformity to guidelines. And this contradicts somewhat the critiques that guidelines are only threatening tools from physicians. And on the opposite, in some cases, guidelines are used by groups of physicians to regain a kind of legitimacy at the expense of non-physicians. Two American scholars, Timmermans and Kolker, report that of the 1,200 guidelines produced between 1999 and 2004, more than half came from within professional organizations, 27 were created by government organizations, and less than 4% came from healthcare business organizations. And we know that even when guidelines are constructed outside professional organizations, for instance in public agency, members of the medical profession still play a major role in their development. This would suggest that professional organizations have still a majority stake in the guideline development field overall. There are some interesting case studies. The first one is by Berg and colleagues. They showed that guidelines had been a tool for insurance physicians in the Netherlands to restore the legitimacy of their decisions, which were criticized by non-physicians. And this does not result to a standardized decision-making for themselves, quite the opposite. In the cancer sector, in the French cancer sector, I show that that guidelines have been developed by a group of cancer hospitals in order to re-legitimate themselves towards French state and patient organizations. In the United States, cancer centers created a cancer network in 1995. This network was deemed to, at the goal to define protocols, and these protocols were designed to resist the imposition of other protocols by managed care organizations. So we'll see well in this process very power struggles are at the core of evidence-based medicine. But evidence-based medicine has also some consequence on the power relationship between medical groups. At the end of the 1990s, I studied the organization of oncology in France, and I found out that there was a fierce competition between specialties and between healthcare organizations. And the network of comprehensive cancer centers had launched a national initiative at the beginning of the 90s to produce evidence-based guidelines. And this initiative helped them to improve their position in the healthcare, in the cancer field, at the expense of the public leading hospitals. And this initiative also helped them to change their relationship to a more cooperative relationship to our community and general hospitals. And this case study suggests that the proliferation of medical guidelines may be also the result of attempts by some physicians to improve their positions relative to other competing physician groups. Guidelines can indeed be strategic resources used by professional actors at the expense of other professionals to maintain a sufficient amount of activity, to increase control of our diagnostic and treatment decisions. And we can draw at least two lessons from this little story for healthcare agencies which produce guidelines. First, this sometimes silent competition can be a lever to involve physicians in the production and implementation of guidelines. And secondly, there is also a risk for this agency to be turned into a tool by some groups at the expense of others. This is my last part of my speech. Debates about standardization on EBM present starkly polarized positions. On the one hand, some advocate guidelines as quality standards that provide universal evidence. On the other, opponents oppose standardization for threatening a human medicine. When one observes carefully what is going on, things are much less clear. As all you know, there are many guideline developers. The length and the form of guidelines, as well as how these organizations manage the process of guideline production, are very different. They are different regarding many factors, including the participation or not of patient organization, the procedural rules, the reviewing process, the composition of the guideline development group, and so on and so forth. But what is even more interesting among these guideline developers, there are many ways to classify the levels of evidence, even if all of them agree and consider systematic reviews of randomized controlled trials to be at the apex of the hierarchy. But the game is on other levels of evidence. Here are, for example, different examples of levels of evidence classification. This one was proposed by Sackett and colleagues, Sackett being one of the big figures of evidence-based medicine, which is slightly different from the levels of evidence by NICE Guidelines Manual in 2007, which is quite different from the levels of evidence by the National Comprehensive Cancer Network in the US, which is much more based on consensus, since our American counterparts think that they do not need evidence-based medicine, since they are the evidence. And which is different from the GRADE project, which is an international collaborative project. Then it then comes as no surprise, there are multiple different guidelines for the same topic. This heterogeneity of guidelines is even less surprising when one observes carefully how guidelines are written. Indeed, there are inherent contingent decisions all along the guideline development process. Guideline production entails a real deliberative process, even if it is framed by methodological and procedural rules. First of all, in practice, the classification of evidence is not an automatic process. Instead, the classification of evidence requires a situated process that draws on diverse sources of knowledge and rules. Empirical work on the actual production of guidelines has demonstrated much more pragmatic and situated evaluation of what counts as evidence and non-evidence. These results strongly contrast to the literature that criticizes IBM for failing to take their other knowledge and the complexities of clinical practice into account. Leus Knappen, a Dutch scholar, there are many Dutch scholars in my presentation, as you may notice, observed many guideline development processes in Europe. In a recent article, very interesting, in 2013, she nicely depicts that what counts as evidence does not depend on evidence hierarchy. Evidence classification in practice requires agreement between members of each guideline development group. And each guideline development group mobilizes a range of other knowledge, such as biological principles, knowledge of the clinic. Empirical study examining the justificatory basis for evidence-based medicine shows the complexity and difficulty of medical classificatory work. The formal evidence hierarchy hides from view all this very crucial work and very important and very noble work. When one is able to observe the process of guideline elaboration, one may notice that participants are careful of the usability of the recommendation, of its scientific robustness, of course, but also of its acceptability. And all this leads to discussions and debates very intense and very rich, whose closure is rarely obvious. This means that there is a social process leading to consensus, which is by nature a compromise, which again is not a dirty word to my mouth, quite the opposite. Another scholar, Tiago Moreira, was able to observe NICE guideline development, and he portrayed the debates taking place during group meetings. He identified different types of repertoire used by the participant to justify the guidelines content. In addition to the robustness or science repertoire, considerations relied upon to justify the guidelines included acceptability, or so to say politics, usability, or so to say practice, and methodological adequacy, of course, which means process. He noticed that participants from different professional groups made preferential use of specific repertoires. And he attributed this fact less to the presence of a priori interests than to the observation that group members envision different future practices and uses. And his results are quite congruent with a study we conducted with colleagues from McGill University on the elaboration of specific guideline in oncology. This guideline was elaborated by what had been the most prolific institution in France responsible for cancer guidelines during the 90s. This is the SOR program, Standard Option Recommandation. It had been one proponent of evidence-based medicine. It had taken part in major initiatives such as the instrument, GENE, and so on. And guideline developers, when we observed their discussions, were aware of the fact that they need to adjust recommendation to prevailing external conditions. How and to what extent remained an open question, and led to discussion about the potential impact of specific recommendation or the impact of a lack of recommendation on a specific topic. By evoking possible scenarios, guideline developers attempted to manage relations between recommendation, users, and other relevant stakeholders. We also show that guideline group meetings cannot be reduced to an exchange of arguments to select a winning position, after which the actual writing of the guideline will amount to a mere formality. This is not a so-called negotiation in the art sense. Textual activities do not happen after consensus have been reached. They are part of the debate and they are part of the consensus. And many guideline developers have come to acknowledge the limitations of quantified evidence and problems of standardized medicine. Some of them, such as the founders of the AGRI instrument, reject the discourse of guidelines as gold standards that will standardize medical practices. They emphasize that in addition to evidence, expert opinions, practitioners, and patient preferences, as well as societal priorities, play a role in standard setting. They conclude that each country has its own norms and values that influence the content and presentation of guidelines. Therefore, the aim should not be to develop international guidelines. But instead of rejecting guidelines and evidence-based medicine, they offer systematic guideline methodology as a solution to this problem. It allows guideline developers to defend evidence-based guidelines while avoiding the unrealistic ideal of guidelines as gold standard, universal gold standards. And different initiatives have been launched to regulate non-coercively the production of guidelines. Here you find some of them. You also see some recurring names, which means that, at least in Europe, they represent a circumscribed network. But even on the issue of developing meta-guidelines, one encounters different guidelines for guideline developers and different strategy to regulate that guideline development. For instance, very recently, the Institute of Medicine proposed 8 standards to assess the quality of guidelines. But these standards have already been criticized, saying that the IOM standards for the development of CPG do not meet their own criteria of trustworthiness. Further studies needed to determine the best methodology to evaluate CPGs. Guideline developers differ also about the strategy to enforce these guidelines for guidelines. Some, such as the Guideline International Network, propose to multiply the exchanges of the working group to share a common understanding of the major stakes and how to handle them. This network was established with European funds, and it now includes guideline development organizations from nearly 50 countries, and every year almost 400 guideline developers attend its annual meeting. So this voluntary network creates, promotes, and disseminates international methodological guidelines for guideline development. But others adopt other strategy. As we say earlier, the Institute of Medicine proposed quite a centralized process. Its working group was quite circumscribed, and some of them recently proposed in the Journal of Clinical Oncology to use this report to promote market mechanisms between guideline developers. They say we do not have an empirical basis for deciding which elements of guideline development are essential to good outcomes. Metrics that distinguish the untrustworthy guideline from the merely good and the excellent are necessary for creating a market for excellent, trustworthy guidelines. The public will gain confidence in the medical profession effort to do what is best for patients. And this is something ironical that physicians came to believe in the so-called law of the market and proposed to use it to defend the position. Indeed, it's ironical because the history of the medical profession made clear that how much the medical profession was a solution for physicians to escape from the law of the market and instead secure a closed professional territory. Though I found this quote very ironical and interesting. To conclude, polarized positions regarding debates are typical for debates around standardization more generally, far beyond the medical sector. Scholars who conducted empirical studies on evidence-based medicine advocate to stop treating standardization as inherently either good or bad. They call for careful empirical analysis for the myriad causes and unintended consequences of specific standards in distinct social domains. Empirical research on guidelines has tempered polarized notions of evidence-based medicine, as advocates and critics alike overestimate the universal and reductionist nature of evidence-based medicine, evidence-based, as well as its ability to standardize clinical practice. I would then strongly encourage ethnographic, sociological, psychological, anthropological observation studies of guideline development to improve our knowledge on this very interesting and very difficult social process at work. And I would then also ask for agency to be supportive of this kind of studies, because I'm sure that it is in their own interest to open their doors, and KCE Symposium is obviously a very good initiative that goes in that direction. And with other scholars, I would argue for the formal integration of the socio-political dimension of healthcare technology into assessment, as well as for an awareness of an identification for the socio-political dimension of guideline development. The ability of health agency to more fully address important issues from a public policy point of view will increase by making explicit the socio-political nature of guidelines and healthcare technologies. I think that paradoxically, this may help increasing the acceptability of their decision. Thank you for your attention.